Assalamu alaikum, telling the SLE management. How can we do the SLE, systemic lupus erythromatosus management? Did you know that SLE dermatomyositis, systemic onset of JIA, psoriatic arthritis and Lyme disease? Management, first of all, I will assess the patient carefully. I will assess the ABC vitals, blood pressure and blood glucose. Okay, ABC vitals, blood pressure and blood glucose. I will examine the patient generally for sign of any steroid toxicity. I will do full musculoskeletal examination with a full range of movement, full cardiac, chest, abdominal examinations, involve senior, involve team. And the features we know more than 4 out of 11. Then the investigation, that is bedside are blood pressure, random blood sugar, glucose and urine dipstick. The lab are full blood count, either normocytic, normochromic anemia or chronic disease, pancytopenia, leukopenia, thrombocytopenia. These are autoimmune hemolytic anemia. Inflammatory marker ESR and CRP, coagulation profile, urinalysis, liver function test, kidney function test. ANA positive, proceed to ENA panel. ENA panel are anti-double stranded DNA, anti-Smith antibody, anti-RO antibody, anti-LA antibody, anti-phospholipid antibody, anti-histone antibody, anti-RNA antibody, anti-RNP. Neonatal lupus is always caused by anti-RO and anti-LA antibody. Complement C3C4. Remember hypocomplementemia. Raised C3C4 is against for SLE. Imaging, we are doing chest X-ray, echo, MRI brain, abdominal ultrasound for hepatosplenomegaly, joint ultrasound for joint aspirations, slit lamp for uveitis. And the advice we are giving: diet and exercise, avoid high calorie, high salt food, avoid steroid induced weight gain and encourage exercise. Sun protection, avoid nephrotoxic drug, education of the family regarding the side effect of medications, report any chest pain, immediately seek medical advice for chest pain. Fatigue and sleep, fatigue is common and affect the school performance, and steroid may induce the sleep disturbance, so lies with the school. Psychosocial issue, education of the child and family about the SLE is essential. Poor school attendance may indicate psychosocial issues. Immunization, live vaccine are contraindicated in those on corticosteroid. Avoid infection like overcrowded places, street food, travel to endemic area, and steroid card and bracelet. Manage, first of all, non-medical treatment are rice, rest, ice, compression and elevations. Medical treatment are analgesic and NSAID. Hydroxychloroquine is the first line treatment, remember. Corticosteroid we can give severe cases IV prednisolone, methyl prednisolone, and oral prednisolone if mild case, or tapered after IV to oral. Immunosuppressive we are giving azathioprine and cyclophosphamide. Remember, anti-TNF infliximab etanercept not used in SLE as it can induce the lupus. For severe disease resistant standard therapy, biological agent rituximab, and plasmapheresis, splenectomy, autologous or allogenic bone marrow or stem cell transplant. Then team involvement are consultant pediatricians, hematologist, ophthalmologist, nephrologist, cardiologist, physiotherapist, psychologist, psychiatrist, or occupational therapist, social orthotist, and hand and foot specialist lies with the school. So this is SLE management. Thank you.